Chris Kyriakou. I'd like to introduce Chris Kyriakou, who is now doing robotics. Are you going to come up like Peter Crouch and do the robot to come up? So who's doing robotic surgery in East London. So again, that's not the dark side, that's okay. Chris is encyclopedic on the subject of PUL, did his PhD on pregnancy of unknown locations, so I think knows more than anybody else out there. So Chris, I'm delighted to introduce you. If you'd like to, you can get up now, it's okay. This is where you sort of stand up and walk over to the podium. I'll hand over to you. So pregnancy of unknown location. A bit early because Siobhan Quenby is stuck on a train, so she's going to arrive for later on. She'll do her talk later on after.
We're saving the best for later. Yeah. Yeah, so do I need to load this myself?
Anxiety obviously increased.
Yeah. Perfect. There we go. All right, so yeah, good morning. Thank you for the opportunity to talk about pregnancy of unknown location. So following a positive urine pregnancy test, a PUL is classified in a clinically stable patient when a pregnancy is not visualized within or external to the endometrial cavity using transvaginal sonography. Now, we know that PUL rates around the world vary quite a lot. There have been published rates as low as 5%, as high as 42%. We know expert scanning units have published rates between 8 to 10%, which matches that work that Professor Bourne spoke about with Emma Kirk's first ectopic pregnancy scan rate of about 74%, subsequent scans over 90%, which is why ultrasound is the gold standard diagnostic modality for ectopic pregnancy. So why do we think PUL rates vary so much? Well, we think it's due to variations in national and international guidance, legal definitions and ramifications of PUL around the world, but also scanning experience as well. Professor Bourne's already mentioned this paper, but in the context of PUL, what we all can do to reduce unnecessary PUL rates is scan asymptomatic patients with a positive urine pregnancy test without an ectopic pregnancy history from 7 weeks gestation. We know that that gestational threshold is safe looking at a large prospective data set. Why do we want to reduce unnecessary PULs? Well, we want to reduce unnecessary hospital visits, blood tests of various forms, and multiple scans for our patients, which of course will be extremely anxiety-inducing, not only for them, but for us as well, which may lower our threshold to unnecessarily intervene on those patients, on those pregnancies, leading to an inadvertent termination of a wanted pregnancy. So how do we manage PUL? We triage them to high versus low risk of clinical complications in order to decide the most appropriate follow-up. The high-risk group, for the most part, going to be ectopic pregnancies, so defined by ESHRA as any pregnancy partially or completely external to the endometrial cavity. There's also going to be a smaller subgroup within that high-risk group known as persistent PUL. These patients have more than 3 serial HCG levels that vary by less than 15%. They make up about 2 to 4% of the PUL cohort. Those at low risk of clinical complications are going to be the normally cited pregnancies or the failed or resolving PUL. The failed and resolving PUL are defined as those that have a negative urine pregnancy test 2 weeks following an initial review where they present with a positive test. Are PUL important? Well, we know that the baseline ectopic pregnancy rate in the UK is about 1.1%. Baseline ectopic pregnancy rate following a PUL classification is 8%, with documented rates between 8 to 37%. So you're 8 times more likely, at least, to see an ectopic pregnancy following a PUL classification. So this is a high-risk cohort of patients that needs to be taken very seriously, which needs to be triaged as accurately as possible. So how do we triage PUL to high versus low risk of clinical complications? And again, PUL is something which is managed so differently around the world. You could speak to individual clinicians, departments, even writers of national guidance, and what they would say would be very different. And this means that follow-up is quite chaotic and very subjective, meaning that doctors are bringing back patients at various time points for multiple visits, blood tests of various forms. Are they looking at HCG, progesterone, HCG ratio? Are they interspersing different types of triaging techniques? And then they're repeating scans, usually by different clinicians as well. So there's a real clinical need to objectively standardize care for the safety of our patients. Really importantly, pending diagnosis, expectant management, for the most part in PUL, is safe, so we don't need to jump in and intervene unnecessarily. They're usually a very stable patient cohort, so long as we triage them appropriately. So in the absence of ultrasound, we have biochemical markers. and they're there to provide a supportive role. They're an adjunct to our scanning and our clinical acumen. They are by no means diagnostic. We do not take HCG and or progesterone to make a diagnosis. Just a very, very quick note on novel biochemical markers, because of course in the absence of ultrasound diagnostics or ultrasound diagnostics that are pending, we need better biochemical markers. There have been about 90 or 100 that have been investigated over the years. None of them are suitable or ready for clinical use. We think there's very exciting world of microRNAs, particularly in endometriosis now as well, but there are two that when used as a ratio are biologically plausible, have some diagnostic potential and predictive potential, but they require further validation in multi-center prospective studies. So after years of research, the two markers that are clinically appropriate and suitable for use remain HCG and progesterone as respective markers of trophoblasts and corpus luteal function. This is a systematic review and meta-analysis that was performed by Shabnam Bobdiwala, who's going to speak later on about ectopic pregnancies. But it looked at the most common triage protocols that try to make the most out of these two markers that we have available to triage PUL. And I've just listed AUC, so area under the curve, which is a marker of discriminatory performance, so the ability to predict outcome following this classification. So the closer to 1, the better. Single HCG is still documented in various guidelines. One of the typical cut-off levels is that of above 1,000 international units per litre, presuming that anything above that level is at high risk of clinical complications. And you can see that this is worse than flipping a coin. It has an AUC of 0.42. We'll explain a little bit why that is later on. HCG ratio is recommended by NICE in UK guidance. Those are the thresholds, so between 0.87 and 1.66, using the data that defines high risk. If you look at the NICE guidance, it's slightly different. Again, those definitions are not evidence-based. These are the criteria that are based on the evidence available. And you can see that the AUC is much better, 0.69, which is actually equivocal to single progesterone. The most typical levels used in isolation are above 10 nanomoles per litre to define high risk of clinical complications, used by some centres around the world, mainly in the UK. The benefit to this is that it's a single visit protocol, but it performs as well as HCG ratio. But we want to get as close to 1, so there's room for improvement. We only have these two markers, so we want to optimise how well they work for us. And so what I'm going to do is just talk through the story of how we got to those 3 triage protocols, and then why trying to optimise them further was the next logical step. So why does single HCG perform so poorly in isolation? Well, this may be known to many people, but I think this figure from this paper really beautifully illustrates it. They only looked at 131 early pregnancies, but that was all they really needed to look at, because all they did was they measured HCG on a daily basis for the first 8 or 9 weeks. And the grey shaded area just shows how broad the HCG ranges are on a daily basis for these normally developing pregnancies. So how can you use a single threshold to define high versus low risk when there's so much variability just in normal pregnancy development? This is some work that we've published looking at over 2,500 prospective PUL from 8 centres. We have just focused on the 2 HCG cutoff levels, not just the 1,000 one, but above 3,000, so we've raised the threshold even more. Again, also published in certain guidelines, the presumption being for both of those thresholds that anything above is at high risk of clinical complications. And you can see that if you use these, you're committing between 12 and 21% of PULs that had a final outcome of a viable intrauterine pregnancy to be misclassified as high risk. And so those are the ones that are at risk of receiving methotrexate and having an inadvertent termination of pregnancy. This is a really interesting paper published by colleagues in London looking at a narrow subset of PUL, so just looking at those in IVF. Why is this advantageous? Well, we know that the gestational age of all of those pregnancies, so we can take into account gestation with a high degree of accuracy, but they only represent a very small proportion of a PUL cohort, only 2.5%. This was retrospective single-centre data, but they proposed taking into account gestation can help calculate a risk of intervention. but this, of course, does require multi-center prospective validation. Last thing about single HCG, and then I will move on, and I just want to finish with this figure. So in blue, you've got your failed or resolving PUL. In purple, you've got your ectopics. In yellow, you've got your intrauterine or normally sighted pregnancies. Just focus on the y-axis for the moment. We put down that threshold. We're saying that everything above is presumed to be high risk. But if we highlight everything below, the vast majority of those purple dots, the ectopic pregnancies, are below that threshold. So that's why it performs so poorly. You're missing the vast majority of your ectopics. Now, the biggest question that I've received when I show this figure is, yes, but do they actually matter? Are they actually just presumed failing ectopic pregnancies that therefore don't need any intervention? Okay, it's great to know about them because having an ectopic is a risk factor for having an ectopic in the future. It's an indication for earlier scans. But do they matter in terms of risk of intervention during this pregnancy? So we have looked at this in detail. So this is 5,500 PUL from 8 centres. This is all prospective consecutive data. Final outcomes of ectopics, 425. Surgery indicated at levels as low as 8. Surgery can be indicated for many reasons. I think the most important one is that rupture was noted with levels as low as 349. So yes, these presumed failing ectopic pregnancies do matter. The risk of intervention is high. So I really hope I've convinced you why single HCG should not be used in pure triage. HCG ratio, as I've mentioned, recommended in the UK. Take the HCG at 48 hours divided by the HCG at 0 hours. This is the high-risk area now highlighted, just focusing on the x-axis and HCG ratio. And you can see immediately why that AUC, that discriminatory performance, is so much better. A lot more of those purple dots are in the right place. Of course, because it's a threshold for ratio, it's got 2 lower risk areas. So the area in blue is the highlighted falling HCGs, so ratio is less than 0.87, likely failing or resolving pregnancies of unknown location. In yellow, the ones with the rising HCGs, likely normally sighted pregnancies. But you can't really ignore the purple dots in both of those shaded areas, which are probably the reason why the AUC is not any better than it is. Now, just experience-based and very subjectively, I'd be more concerned about those in the yellow area because they've got rising HCG, and you would think, okay, they're probably proliferating, they're probably at risk of intervention, we really need to safeguard quite carefully. What about those in blue? They've got falling HCGs, do we need to worry about those as well? And the data suggests that we also do need to worry about them. Surgery is indicated with HCG ratios as low as 0.49, so even though the HCG was halving over 48 hours, some of these patients still required surgery, and rupture was noted with HCG ratios of as low as 0.69. So look, it's every unit uses these biomarkers differently for their PUL triage protocols. If you're using HCG ratio, it definitely outperforms single HCG, but you just have to be aware that it is not perfect. It is going to miss cases that do matter. There is an intervention risk even for those ectopic pregnancies that are presumed to be failing. And so we need to be counselling these patients very, very carefully and ensuring that they are safety netted to come back in if they have any pain. There's a lot of point-of-care devices now coming out, and there's a lot of units that we're working with as they're rolling it out. We know that if you're seeing a patient at time 0 and you're sending a blood sample off to the lab at time 0, you send the blood sample at 48 hours to the same lab. Otherwise, your HCG ratio is going to be incorrect. If you're using point-of-care testing at 0 hours, then you do the same thing at 48 hours. You have to use the same technology at both time points, otherwise it does not work. So that's HCG in a nutshell and how it all evolved. Single progesterone, like I said, equivocal to HCG ratio, can only see the patients once, which is great for workflow and efficiency, but you exclude a number of patients, increasingly so since the changes in NICE guidance and the results of the PRISM and PROMISE trials, because essentially anyone that's taken progesterone for IVF, recurrent miscarriage, or previous miscarriage with bleeding, you're not going to be able to assess those progesterone levels in detail. This is some data published by Sharmista Guha, who was a fellow from a number of years ago, and I'm only really highlighting it just to show that if you use the commonly used threshold of above 10 to define high risk of clinical complications, you do in fact capture about 3/4 of your ectopics correctly. What's really interesting but hardly surprising is that the vast majority of your normally cited pregnancies are also in this category as well. So there is already this query here about how useful progesterone is as a marker of viability, not location viability, but we'll talk about that in a second. If I just translate that table into this figure, so now your failed or resolving PUL are in red, your ectopics are in black, your in utero pregnancies are in blue. When we put the threshold, you can see the vast majority of those black dots are indeed above that threshold. Again, you miss 1/4 of your ectopics. These are presumed to be the failing ectopics. And again, they do matter. Looking at our cohorts, surgery is indicated with levels as low as 1 nanomole per litre, and rupture was actually noted as low as 2. So again, also equivocal to HCG ratio, does have its own benefits, does have its own limitations. You need to accept that it's not perfect if this is what you're using, and you need to counsel your patients effectively. As a discriminator of viability, if we then talk about those blue squares that are all above, there are very few below that 10 threshold, and there's almost none if you lower the threshold to 2, which is what we've done as part of our work. And we found that if you use a cutoff of 2 as a single visit protocol, you can safely triage over 1/8 of your PUL as low risk at time 0, so they don't need to come back 2 days later, so long as you safeguard them and that you ask them to do your own pregnancy test in 2 weeks' time. So it does have its uses. So like I said, we can't use ultrasound because we can't find the pregnancy. We've got limited biomarkers, and we've looked at lots of them. We've looked at some clinical markers as well, and they're not useful in isolation. So we really do only have serial HCG and progesterone. There's data on serial progesterone, and serial progesterone isn't that helpful either. So all we have are all of these markers, and they have their own benefits, but they have their own limitations. And that was the logic behind merging them and using statistical modeling with large data sets to try and optimize how well they work for us. So everybody talks about modeling, and people think, okay, but you just put some numbers in and then it gives you an answer. This is just taking advantage of all of our understanding of single HCG, HCG ratio, and single progesterone, and just making it work in concert. And so obviously with greater numbers, the more generalizability it has. And so in the last year, we've published the most updated version, which is multi-center, prospective, consecutive, and definitely has quite high area under the curve. All you need is HCG at 0 and 48 hours, and then if you have a progesterone level, you can add it. It can work without. If your risk is 5% or greater of ectopic pregnancy, then it will say that it's presumed high risk. If not, low risk, and it will define whether it thinks this is a failing or resolving PUL or a normally cited pregnancy. But it will also provide objective management advice that has been clinically implemented and deemed safe. So it's great for anyone in training. If if you work in a unit that is consultant-led, but it's actually, there's a lot of nurse sonographers who are looking for some advice on a daily basis, with regards to the outcomes of their 48-hour results. This actually allows you to phone the patient, let them know a plan, and has been tested. So this was the external validation, so that was subsequently performed. And you can see that even without progesterone, sensitivity for the high-risk outcomes is very high. The ability to exclude those at low risk is also very high, and its ability to discriminate is at least 20% greater than any other triage protocol we have at the moment. It doesn't take advantage of that initial low progesterone, so what we introduced was asking the question of whether the progesterone is low at the beginning, and if it is, then they don't actually need to use the model. They can be discharged safely with safeguarding. But if you have a high progesterone, then you move through to the model. So if you do have a progesterone level, you can do this whole 2-step triage, but if you don't, it doesn't matter. You can still use the M6 model and take advantage of the benefits of optimizing single HCG and HCG ratio in combination. So going back to that original slide, there is a lot of evidence to explain why misclassification rate is quite high. We are missing ectopic pregnancies that are presumed to be failing, that have an intervention risk. That therefore means that these patients are at risk of significant harm and morbidity, which can have long-lasting psychological implications. By optimizing how all of these work within modeling, we can outperform all of them combined without increasing the number of visits beyond 2 visits. And this model has actually been recommended in previous ISWAL consensus statements as well as RCG guidelines. But it's really important to remember that with any triage strategy, you don't blindly follow the markers. They are an adjunct to ultrasound and clinical judgment. So if you have to deviate from a protocol, no matter what protocol you use, because the patient has suddenly got pain the next day, then that's what you do. You don't just blindly follow what your triage protocol says based on the markers alone. And like I said, the evidence suggests that it is the most effective approach. You can direct all of those much needed resources to the patients that need them without unnecessarily following up low risk cases. You can support those in training because we all don't start as expert scanners. It's a learning curve, and you get objective follow-up advice provided, and you don't need progesterone. And it is just really important to remember that all of this is due to the fact that the danger arises from ectopic pregnancies. We know that the risk of ectopic pregnancies is greater in this cohort. We know that if we miss them, there's an intervention risk, and that's why it should be as accurate as possible. So we're continuing to validate. We've looked at clinical factors like maternal age, history of ectopic pregnancy, pain scores, bleeding scores, and those in combination are very good at replacing not having progesterone in certain centres. So that's something that we're looking at in a bit more detail. These are independent external validations around the world, most of them in Europe. You can see the discriminatory performance is equivocal, most of them without progesterone, because a lot of centres don't actually process progesterone levels, which is why there are 2 iterations. A lot of this is retrospective, and interestingly, there was a study in Ireland which didn't perform as well, but that was due to their definitions of their PUL risk outcome groups, as well as different populations. And that is the whole point of modelling. If you validate more, and these are in yellow, all the places that are independently externally validating at the moment, you can improve generalizability, but also if you have enough data, then models can be calibrated towards your population group so it works as best for where you're working. So any model is now a medical device, which is a very arduous and quite expensive, lengthy process in order to get registration. So we're working with an entity called Guinea. You may have all heard of the ADNEX model. That, in concert with the IETA model and this model, are now going through that regulatory process, and that is why this entity exists. This is just very summary data showing detection rate of ectopic pregnancy, and you can see of all the options, it does outperform everything else. You can't use it if the patient is under 16. You can't use it if you've already seen an ectopic. You have to have your levels taken from the same laboratory. If you pass that test, then it will allow you to use it. It will ask you about step 1. If you have a low initial HCG, then it will advise that you actually don't need to use the model, and it can just advise a urine pregnancy test. But otherwise, you can just input your levels and progesterone status, and it will give you a probability, a risk outcome, and then you can follow the follow-up pathways in terms of repeating scans, urine pregnancy tests, and HCGs at the time points that we've discussed. So that is the story of PUL. I wish there were more markers that we could talk about, and that was a lot of my work as well. And I do think there are more markers that are coming. But in the absence of ultrasound, we really only do have those markers. We need to optimize them as much as possible. And I do think this is the logical next step to standardizing care for the safety of our patients. Thank you.
Thank you so much, Chris. Whistle stop of PUL and amazing work you've been doing. I think the last point, one of the last points you made is also so important, because I see this so often. People get confused and put HCG data on models, even in our own unit, on a visualized ectopic.
Yeah.
But we just have to, can you just clarify that what you're talking about is a model for PUL, not those with the visual, which is a separate.
So there are 2 things. So firstly, people have commented before that PUL is a diagnosis, and it's not. It is a bridge to diagnosis, and triage techniques are to aid that journey across that bridge. So once you get to the other side of that bridge and the diagnosis, then that's when you...
Yeah, exactly. Any other questions from the audience or? No, well, oh, so sorry. Yes, there is one. Thank you. Please, just the microphone.
Thank you. Thank you for your presentation, Doctor. Is there any moment that is better to take the progesterone than other moment, like any time of the day or when you're doing the diagnosis?
I would say in the context of using it for PUL, no. There's been a lot of, so prior to this, and I didn't show the data, there's been a lot of longitudinal progesterone level work, and throughout the course of early pregnancy trajectory, surprisingly, even though it's intricately related to HCG and the release from the corpus luteum, your progesterone level subjectively remains quite stable. Yeah, and that's why we've always talked about single progesterone, and that's why there's been no other triage possibilities that have been developed with multiple progesterone time points.
Thank you very much.
On the topic of, sorry, I'm switched on timing. How much leeway have you got when you repeat your second HCG? Because people often say, come back in 48 hours, but the reality is, you know, they come at 3 o'clock one day, they come back at 9 the next. Does that matter, or what's the story there?
So so linked to your question, I mean, HCG, of course, is a dynamic biomarker, and so all of this has been developed so that you have a 16-hour window, which is a bit more realistic for what we do in clinical practice, because, you know, sometimes they do come in at, you know, the patients come in at unsociable hours, and we can't get the exact time point. So long as they have the second HCG at the 48-hour time point plus 8 hours or minus 8 hours in that 16-hour range, then it's feasible and it should work. Yeah.
Perfect. Thank you so much, Chris. So sorry we could chat more, but in the interest of time, we have to move on.